Welcome back, folks. To talk to us about the unique risk factors and concerns for LGBTQ patients is Susan Kaliszewski, physician assistant in the internal medicine program at the University of Iowa Hospitals and Clinics. Susan has worked in the LGBTQ clinic since July of 2017 and has been an advocate for this population really since the 1980s when, as an undergraduate, she studied HTLV3 before it became known as HIV. Susan, let's hear it.
Hi, my name is Susan Kaliszewski, and I'm a physician assistant with the University of Iowa LGBTQ clinic. I'd like to thank Amy Perlman and the organizers of this conference for inviting me to speak to you today. I'm going to take a moment to switch to the slide view so you can see what I am presenting. All right, there's my title slide. And these are the folks from the LGBTQ clinic. I have nothing to disclose today, and these are our learning objectives. I want to start off with a quote from a gentleman who was affected by cancer within the LGBTQ community. It's a bit sobering, but it represents what's important about our discussion today. If I had the choice again, said Scott, I would take my risks with the cancer and not have the operation. He said that the loss of erections after robotic prosthetic surgery was a defining moment in his life. The impact of his life as a gay male has been really profound and in a negative sense. So I think that will kind of shape our discussion today to think a little bit about how people can be impacted with regard to cancer within this population. First, I want to go over some definitions for us. First of all, we have the very definition of the community, which is LGBTQ. This stands for lesbian, gay, bisexual, transgender, and queer or questioning. And we have about 3 to 12% of the US adult population self-identifying as part of this community. Approximately 5% of women identify as lesbian or bisexual, and about 3.9% of men identify as gay or bisexual, and about 0.42% of the US population identifies as transgender. Here's a little map of the US, which shows, unfortunately, some discrepancies among the population. And I think this is probably not incredibly accurate because we see a relatively low population in the Dakotas and a relatively high population on the coast. Probably represents what people are willing to disclose more so than the actual distribution of adult LGBTQ folks in the US. Further definitions, sexual orientation and gender identity are obviously important, and they're very distinct and separate things. Sexual orientation is what we think of as traditionally lesbian, gay, bisexual, queer, somebody who has a romantic or sexual attraction to a person of the opposite sex or gender, whereas gender identity is a personal conception of oneself as a male or a female, very much located in the brain. So somebody who is born male, sex assigned at birth is male, may identify in their brain as female, and that is a trans woman. A trans man would be the opposite, somebody who identifies as male, but their sex assigned at birth was female. A non-binary individual is somebody who doesn't really want to fit in the box of male or female and may present as more agender or asexual, or a non-binary. Asexual means not having interest in sexual activities, so that's a different thing completely. Factors affecting cancer risk, which we'll discuss today, include the fact that among this population, unfortunately, there is a lower average income. And a specific number to keep in mind is that 41% of the LGBTQ population have incomes at or below the federal poverty level, which is really a terribly disheartening statistic. In addition, as a result of that, a lot of these folks have low rates of health insurance as well. And so that limits their access to health care, which can unfortunately cause them to be diagnosed with cancer at a more advanced stage, and certainly affects their ability to undergo preventive measures as well. Important statistic which represents this fact is that 30% of folks in this population do not seek healthcare services or lack a regular provider compared to 10% of age-matched heterosexuals. So that's kind of a disturbing statistic as well. Further, many people in this population are not comfortable disclosing information about their sexual orientation or gender identity with a provider due to fears of stigmatization or other reasons. And providers may lack knowledge of folks in this community and their specific needs. For example, the National LGBT Cancer Network says that 60% of oncologists don't feel as though they know enough to treat LGBTQ folks, and 80% of oncologists don't feel they know enough to treat trans people. Further factors affecting cancer risk, which may be unique to this population, is that they tend to have a higher incidence of HPV infection, as Dr. Nicely is discussing today as well. And you'll learn a lot more, or you have learned more about that from her. Unfortunately, that infection increases the risk of cervix, anal, vulvar, penile, oral, and throat cancers. So all of these folks who are infected with HPV are at high risk for those cancers as well. In addition, we know that tobacco use is 40 to 50% higher in the LGBTQ population compared to the non-LGBTQ population. And obesity rates and nulliparity rates are higher among lesbians and bisexual women. And finally, alcohol use is higher among some subsets of this population as well, putting them at risk for different types of cancers. We know that lung, breast, cervical, and liver cancer rates are higher among this population, and that this population is also at higher risk for ovarian, endometrial, anal, esophageal, and colorectal cancers because of the demographics and because of the exposure risk factors that we previously mentioned. A particular number that's a little bit frightening is that gay men are 1.9 times more likely to report being diagnosed with cancer than non-gay folks, and women in same-sex couples are more likely to have fatal breast cancer compared to heterosexual women. Psychological effects of cancer are also significant, and so I'd like to mention that, and the symbol on the right is to remind you that the brain is a big player in sexual satisfaction and sexual activity in general. And so if you are, as a result of cancer therapy, feeling less attractive or not feeling well in general, or feeling worried or stressed or depressed, certainly that is going to play a major role in your sexual satisfaction and sexual activity. As a consequence, because LGBTQ folks sometimes are more stressed and more depressed and more worried, and particularly trans folks are at higher rates of suicide compared to the general population, that can certainly impact their sexual activity as well. I'd like to delve into specific types of cancer now, and we're going to talk first about anal cancer, which is relatively rare. It is about a 0.2% lifetime incidence, but unfortunately, HIV, which is more common among the LGBTQ population, increases your risk of anal cancer by 9-fold. HPV infection is also a causal factor, and that can obviously be passed through intimate contact, not just actual sexual activity, but skin-to-skin contact can transmit HPV as well. Other factors include high number of lifetime partners, coexistence of STIs, cigarette smoking, and immunosuppression. And immunosuppression is particularly important for HIV-infected folks because we know that they are actually at 40 times higher risk than the general population for anal cancer. And HIV obviously is an immunosuppressing condition. Going on to anal cancer and sexuality, there are few studies that have been taken for reports by sexual orientation or gender identity. However, we do know that in the general population, there are higher scores for fatigue, dyspnea, insomnia, diarrhea, and reduced global quality of life among survivors of anal cancer, and that results in significant impairment in social and role function. survivors also reported increased stool frequency, more buttock pain, flatulence, fecal incontinence, impotence among males, and reduced sexual interest and dyspareunia among females. It can certainly be inferred that sexual impact would be significant for men who have sex with men in particular, given the importance of anal intercourse among that population. This is a slide that represents the degree of impaction with regard to anal cancer survivors. If you look at the dark lines, they are showing the various degrees of these symptoms within anal cancer survivors, and the lighter lines are among age-matched and sex-matched volunteers. So clearly, impotence in men is a significant problem for anal cancer survivors compared to volunteers, as well as flatulence and buttock pain, and those things will all impact sexual functioning as well. Moving on to breast cancer, this is the most frequently diagnosed cancer in women. Risk factors include age, tobacco use, obesity, and alcohol use. And as we've already mentioned, LGBTQ folks are at higher risk because of their higher incidence of tobacco use and alcohol use and obesity. There is no direct data on the LGBTQ population, but there have been some geographic studies which overlie density of LGBTQ population with incidence of cancers. And these were mostly done in California, so it's hard to know if we can generalize them to the entire population of the US, but that's the best information that we have, unfortunately. So with regard to trans women and trans men, breast cancer is not thought to be a higher incidence among these population compared to their controls, which in the case of trans women, we're comparing to cis women or women who were born sex assigned at birth women and identify as women. So trans women obviously are on estrogen therapy for a prolonged period of time if they choose to do so. And one might think that that would put them at higher risk for breast cancer. It turns out that they are not at increased risk compared to cis women despite estrogen treatment. On the opposite side, breast cancer incidence in trans men is comparable to cis men. So in other words, when people are on testosterone, it actually reduces their risk of breast cancer. And in many cases, trans men will have gender-affirming top surgery, which will remove some, if not most, of breast tissue from their chest. However, it is important to remember that we need to examine them because some residual breast tissue may remain. And so examining the scars from a chest male reconstruction surgery among our trans male patients is important to detect cancer as they age. Breast cancer and sexuality. Obviously, again, the brain is playing a big role in what's going on here. So we need to be sure that people feel okay about their bodies post-treatment for breast cancer. A lot of unfortunate side effects to those treatments result in fatigue and vasomotor complaints and poor sleep and cognitive impairment, which can all affect sexual desire, self-image, and sexual function as a result. Sexual minority breast cancer patients are more likely to report sexual activity, reduced sexual activity frequency, reduced desire, and ability to reach orgasm, as well as higher levels of pain compared to healthy controls. So we do have a little bit of information in the sexual minority community on breast cancer specifically. Moving on to cervix cancer. Again, one of those density studies tell us from the California Health Interview Survey that lesbian and bisexual women tend to have higher prevalence of cervix cancer, with about 41.2% relative compared to heterosexual women, and that was bisexual women compared to heterosexual women. So that's kind of frightening that they're that much higher, almost 3 times higher compared to heterosexual women in that particular study. We're uncertain if this data is generalizable, We do know that HPV is, of course, an important risk factor, and smoking as a cofactor. And we know that sexual orientation, when we divide that into smoking behavior, then unfortunately, bisexual women tend to be higher rates of smokers compared to heterosexual women. And actually, lesbian women tend to be lower rates of smokers, so maybe somewhat protected compared to bisexual women. For sexuality discussion about cervix cancer, there is no data by sexual orientation. However, we know that treatment for cervix cancer has great impact on quality of life, with radiation therapy causing the greatest risk for long-term bladder and bowel dysfunction, which can lead to sexual dysfunction as well. There is a more frequent report of pain and decreased sexual interest after cervix cancer treatment among the general population, and likely this is true for our LGBTQ folks as well. With regard to the next cancer, colorectal cancer, again, unfortunately, we have no data on sexual minorities, but we do know that risk factors include age, family history, obesity, a diet heavy in red meats, heavy alcohol use, smoking, and inactivity, which again are at somewhat higher incidence among this population. Once again, we have the California Cancer Registry and health interview survey showing significantly higher incidence in geographic areas with higher density of bisexual men. And a county level association showed higher incidence of colorectal cancer for men and women, which correlates with sexual minority density. So again, this is not direct data, but indirect data that tells us that these people probably have a higher incidence of colorectal cancers than the general population. Impact on sex for this particular type of cancer, unfortunately, again, no studies specifically by sexual orientation or gender identity, but in general, survivors experienced lower physical and mental quality of life, and long-term treatment effects included, unfortunately, fatigue, fear of recurrence, anxiety, depression, sleep difficulty, negative body image, neuropathy, gastrointestinal problems, urinary incontinence, and all of that, of course, can lead to difficulty with sexual functioning and feeling good about sexual activity, as well as straight up sexual dysfunction directly from the side effects of those treatments. The next type of cancer I want to discuss is endometrial cancer. And while risk factors would suggest that this would be higher prevalence in lesbian folks in particular, who are known to have less pregnancies during their lifetimes and higher incidence of obesity, it turns out that older lesbian and bisexual folks who have been studied in the Women's Health Initiative, actually, those folks that never had sex with men have a decreased prevalence of endometrial cancer compared to heterosexual women. With regard to sex, very much impacted by the type of surgery, either laparoscopic versus laparotomic or vaginal surgery, and obesity is in general associated with poor quality of life outcomes, including physical functioning. But this information is from the general population and not specific to our sexual minority populations. Next cancer to discuss is lung cancer, which is, of course, the leading cause of cancer death in the US and in the world. Higher incidence and mortality rates in geographic areas, again, with greater density of sexual minority males. And there is a lower incidence of cancer, actually, and mortality in areas with higher density of sexual minority females, which is probably because gay men and bisexual women have higher incidence of smoking, and lesbians and bisexual men have lower incidence of smoking and may be actually protected somewhat from this type of cancer. HIV infection is an independent risk factor for lung cancer, as well as, of course, smoking. And unfortunately, we don't have any specific quality of life data with regards to sexual orientation. Probably the most impactful cancer with regard to sexual functioning is prostate cancer within this population. And so I'm going to spend a little bit more time discussing that specifically. This cancer is second only to skin cancer in frequency of cancer diagnoses in men. And once again, in California, we have a little bit more information. Gay and bisexual men actually have a lower prevalence compared to heterosexual men of prostate cancer. However, because this is such a frequently diagnosed cancer, And because we have a high population of gay and bisexual men in the general population, we think that there are probably likely at least 5,000 gay and bisexual men diagnosed with prostate cancer every year, and probably 50,000 or more survivors. Risk factors include advanced age, African ancestry, geographic locale, and family history, as well as smoking. There is actually no difference between gay and bisexual men and heterosexual men in terms of PSA testing. So that's good. It seems like these folks are getting PSA tests, and that's a hopeful indicator that they're getting diagnosed in a timely fashion. However, there is a population that is unfortunately not getting tested to the same degree, and that is the bisexual African American population, and that compared to the heterosexual African American population, which is actually tested a little bit better. And if we compare bisexual African Americans also to the general gay or bisexual population of whites, unfortunately, African American bisexuals are tested at lower rates. So that's something that we need to be thinking about. With regard to prostate cancer and sex, as our initial quote discussed, this is very impactful for these gentlemen. Their sexual practices include anal penetration, but also anal stimulation of the prostate through receptive anal intercourse. And that is very much a pleasure center. So this is definitely impacted when prostate cancer is treated because of radiation or surgery. Fortunately, many of these gentlemen can learn other techniques that bring them pleasure. And so anal stimulation may also bring sufficient pleasure, and they can learn to appreciate that as well. One important factor to remember is that with prostate cancer, there is a high degree of difficulty with erections. And so unfortunately, erection firmness is very impactful in this population, because if the erection is not firm enough, it's unlikely to be able to achieve anal penetration, and thus prevent successful sexual activity that people were used to when they were younger and before they were treated for this type of cancer. There is also an important thing to think about, and that is that treatment for prostate cancer can affect ejaculation. It can cause retrograde ejaculation, and this is actually something that's very important within the gay and bisexual male population. They like to have the visual reassurance of having that ejaculation occur is something that's stimulating to them. And so if they don't see that and can't see that because of retrograde ejaculation, it can be a loss of pleasure with regard to sexual activity. In addition, I have a couple of studies that actually did look at gay men specifically. Unfortunately, they suggested that poor outcomes and decreased quality of life in gay men compared to heterosexual men were present with regard to prostate cancer diagnoses. And another study found significantly worse sexual bother, ejaculatory function, and ejaculatory bother in gay and bisexual men after prostate cancer treatment. Prostate cancer in sex with regard to erectile dysfunction, urinary incontinence, fecal incontinence, and tenesmus. These are treatment-related complications which can have long-term effects on sexual function in general. And with regard to gay and bisexual men specifically, who have been diagnosed with prostate cancer, there was a very specific study which was helpful, and unfortunately not very good news with regard to people who were treated with radiation therapy. Among gay men and bisexual men, the role that an individual takes on in a relationship is often very important. The top partner and the bottom partner tend to remain static, although there are some people who are versatile who may be top or bottom partners. So when it comes to radiation therapy, all the people who underwent radiation therapy were able to retain their pre-treatment role of being the top partner or the bottom partner. But after surgery, only 1 of 4 people in this study retained the role of receptive anal partner, and 0 of 3 men were able to retain their insertive role, again, probably because of the difficulty obtaining erections in people who have been treated for prostate cancer. That's my conclusion with regard to the summarization of the various types of cancers. And I wanted to just go over a few things with regard to caring for LGBTQ folks in the situation. I want you to know that you should do as much as you can to establish trust with patients, because they may be a little bit less likely to trust care providers. I've certainly experienced that with regard to my practice, and it takes a while to develop that trust. But one way you can provide a welcoming atmosphere is to wear a pin which identifies your personal pronouns, whether they be she, her, hers, he, him, his, or they, them, theirs, and also to wear a gay pride flag, which identifies you as a welcoming person in your clinic. There is also information available for cultural competency training, and this is just one location on the screen. It's very important, obviously, to obtain a full sexual history, including partners, types of sexual practices, and past problems or concerns, or you're not going to be able to help your patient with regard to any current concerns, and they may not feel like they can bring those up in your discussion. It's important to recommend smoking cessation to help your patients attain and maintain a healthy weight and avoid excessive alcohol use. It's also important to provide an open door for professional therapy if that's indicated, and treat mood disorders if that's indicated among people who have been treated for cancer. And among this population, as we learned, there is lower access to healthcare. So I would recommend that you attempt as best you can to be an advocate for access equity in healthcare, because that is a way that these people can get better attention and hopefully earlier diagnosis and treatment. I'm available for any questions that you may have later in the day, and I would welcome those. I want to thank you very much for inviting me again to speak at your conference, and I hope you all have a wonderful day.
Wow, Susan, you bring up so many points with that presentation, and thank you for joining us live today to address some additional questions from the group. And I have some of my own questions for you, because this talk was really relevant to my patient population. And when you mentioned the research that's been done on the ability to engage in pre-treatment sexual activity after radiation and surgery, well, wow, then we have to figure out how our patients engage in intimate situations before we offer them treatment. And that has to really play a larger role in our surgical discussion. I don't think this shows up anywhere in our national guidelines for how we talk to our patients with prostate cancer about whether they undergo radiation or surgery. It's really based on PSA and their comorbid conditions. I haven't seen anywhere in there where it says, consider how your patients have sex. Have you seen anything in the literature about that either, in terms of deciding on treatments?
I certainly can't speak any better than you can, Amy, to the specifics of prostate cancer and treatment. But no, unfortunately, I think that's often not considered when it comes to cancer treatment in general. It speaks to the necessity of us asking questions ahead of time, just like you said. If we can get to know our patients a little bit better and understand what they are doing in their personal relationships, that would certainly help them in the long run, trying to avoid complications that could perhaps be avoided. Absolutely.
And you mentioned during your talk as well, that some men, especially those who have sex with men, really are bothered by that retrograde ejaculation, where the ejaculate maybe goes back into the bladder and then they pee it out. And I think, some of us, might say, oh my God, but we cured their cancer. So why would someone be upset about that? And we can't make any assumptions, right? Because I have cisgendered men, and I have men of all ages, guys in their 30s up to their 90s, where something like that seems so benign to us can be so bothersome. Have you been surprised by some of these concerns that men come in to see you with, even despite a history of cancer?
Yeah, I could say that's definitely true. And you know what they say about assumptions, we don't want to make any of them. And certainly it is a problem. I can't say that I can speak too much with personal experience with regard to cancer, not nearly as much as you can, but in particularly in the gay population, this dates back to the age of HIV, right? When ejaculation was something that had to be hidden by necessity. Everybody had to use condoms, and we still recommend people use condoms, but within an intimate relationship, if you're monogamous, it's not as much of a risk factor and people don't use them. So it's something that feels tremendously freeing to our gay population to be able to ejaculate. It helps stimulate their brain. It helps them feel stimulated with regard to sexual activity in general. And so taking that away is really, it does play a role. It plays a factor that we have to consider when it comes to what's going on in their private lives. Absolutely.
Yeah. So let's talk a little bit about what that perhaps in-office visit looks like. And let's say you're about to do a physical exam and you want to talk to the person about, let's say, prostate health or colorectal health, cervical health. How do you use those terms? So if someone identifies, sex assigned at birth male and identifies as female, and you are going to do a genital exam, how does that conversation look like? What words do you use when you're doing the exam with the patient?
Yeah, that's an excellent question. And it's something that I think we can all try to pay a little bit more attention to, because a lot of times our trans folks are very sensitive about their genitalia. They're very dysphoric about it. They don't really want to talk about it too much, and they're really not sure they want anybody to examine that area either. So first, ask permission. Is it okay? I would like to discuss this. I think it's important to your health. Can we discuss this today, or would you like to choose a different day? Would it be better for you to consider having a pap smear at a future date so you can prepare yourself? That is not at all uncommon among my trans men population for me to say, you know what, we really need to think about doing this. How can we go about that best? How can we decide to do this in a way that would feel most comfortable to you? Because they are guys, they do not run a lay on their back in the dorsal autonomy position. They do not want to have that area examined unless they really need to. And if they do, they want to feel pretty comfortable. They want to feel like they know you and not have that done by somebody that they've never seen before, probably. So I tend to offer that and then sort of schedule it. And maybe even on a separate visit where they can come and just have that done and be in and out real quick so they don't have to think about it too much. Same thing when it comes to discussing this, is it okay to talk about your bottom parts? We've got some parts that we need to attend to. You're a young transgender woman and you've got a testicle. We've got two testicles that we need to deal with. So we need to think about the possibility of testicular cancer. Can I examine them today, or should we do that at a future date? So basically just, talk to the patient in terms that they can understand and use words that make sense to them. Sometimes you can just say bottom parts, right? That's okay. They know what you're talking about. But if you need to be specific, for example, about a testicle, it's okay to say testicle as well to a trans woman. That's not going to offend them. They know what parts are there. And I see in the chat, if you don't mind, I'm going to divert for just a second because somebody asked about the follow-up on trans patients and cancer. Do trans men get routine cancer screening that cis men do? Or do they still need to be screened for cancers that are more pertinent in females? And the answer is, what are the parts that they have, right? So if a trans man has, like I said in the talk, any residual breast material after having gender affirming top surgery, then you need to take a look at those scars and examine what parts they have. And any screening would be based on the parts that they have. So if a trans man has not had gender affirming top surgery, and they've reached the age where we need to consider mammography, then absolutely we should get that scheduled. Our trans women will develop breasts. They need screening for mammograms. They need screening for breast cancer. And the same thing is true for cervix cancer for our trans men, for example. So it all depends on what parts they have.
Awesome. And the other thing that I found actually to be helpful in my clinic, because although a lot of the patients I see are cisgendered men, I also see patients who identify as female and who are interested in bottom surgery. And I'll ask them before I am planning on doing the exam, how do you call your genital parts? For example, some people say testicles, balls, penis, front hole, back hole, cock. And some people look at me and they're like, oh my God, Perlman, what are you saying? But I think the point is we have to meet our patients where they are. And if they use language or slang terms for their parts, then we just, as healthcare providers, have to get comfortable doing it. And I think the time to ask how they refer to their genital parts is before we ask them to lower their bottoms. And most of the time, the patients, at least that I see, say, I just don't refer to those parts. And so when I'm doing the exam, I won't say testicle or penis. I'll just say, this is where I'm planning on making the incision. You can go ahead and bring your bottoms up, which is a little bit different for how I may have the discussion with a cisgendered man. When I do his exam, I'm actually teaching him about his body as I'm doing his exam. And I'll say, your left testicle feels normal. Your left epididymis is normal. And then as he's bringing his bottoms up, I may say, everything looks and feels normal, because for a lot of men, they haven't been told that before. But the subtle difference there is I don't tell my transgender identified patients that everything looks and feels normal, because to them it's everything but that. So sometimes those subtleties can certainly go a long way. Susan, always good to hear from you. Thank you so much for your time today.
Thank you all for inviting me. Appreciate it. Have a wonderful afternoon. Take care.